It's a real privilege for me to be able to introduce to you Brian Bumbarger. I think Brian represents one of the most unique persons to come speak to us about what's called translation work. I'm not sure I like that term, but when we talk about the new frontier for prevention science, it really is in the area of the dissemination and implementation of programs that we know are effective. So having good programs that are effective is simply a beginning point, and the issue, if we are to take these programs to scale, really has to deal with the issue about what do we know about dissemination, how programs are selected, and what do we know about the implementation and how we can implement programs with fidelity. And Brian is uniquely qualified to speak to us about that issue. He has an imposing title, the Assistant Director for Knowledge Translation and Dissemination. And I think that says it pretty well. He is also at the Prevention Research Center at Penn State. He's a research fellow at Griffith University in Queensland, Australia. And he's the PI and the founding director of the Evidencebased Prevention and Intervention Support Center, or EPIC. He has done extensive work on scale-up in the state of Pennsylvania, and at this point I believe he's been involved in scaling up over 300 blueprint programs in the state of Pennsylvania, and he's been the PI on several longitudinal studies looking at dissemination and implementation. He also serves on a number of national boards, I think, which lend credit to his skill and knowledge in this area. So he's on national panels at the National Institute on Drug Abuse, on the Department of Education, Centers for Disease Control and Prevention, and he is elected to the board of directors at the International Society for Prevention Research. So it's a great privilege to have Brian speak to us. So give Brian a warm welcome.
Good afternoon, everyone. It's really an honor and a privilege to be asked to give this plenary address at the conference. I've been involved with the Blueprints conferences since the very first one, I believe. So it's been exciting to watch the evolution of the Blueprints initiative and the spread of the interest in blueprint programs throughout the country over the years. Okay, well, this is a relief to hear some chuckles. This tells me that at least some of you watch Game of Thrones and get this reference, and that's good. I credit my 19-year-old daughter, Kylie, for this opening. Kylie has, she's been involved in musical theater all of her life, and so she's my go-to person for consultation on public speaking engagements. And Kylie told me two things. She said, "Go with the pink tie, Dad. That one has worked in the past." And then she said, "You can't go wrong with memes, Far Side comics, or Game of Thrones references." So we'll see if that holds up. So here's our agenda for the next 30 or 40 minutes between salad and dessert. And please, as Dell said, please feel free to keep eating. I'm not offended by that at all. If you do hear something interesting or valuable, please go, ooh, as a signal to the other people at your table to look up once in a while. The initiative to scale up the blueprint programs in Pennsylvania has been going on for nearly 20 years. So there are a lot of folks to acknowledge, academics, state policymakers, and many providers and practitioners. But in particular, I want to recognize the folks at the Office of Juvenile Justice and Delinquency Prevention at the Pennsylvania Commission on Crime and Delinquency, both past and present, including Clay Yeager, who you heard from this morning. The commitment and leadership from the Pennsylvania Commission on Crime and Delinquency has really made Pennsylvania a leader in the use of evidence-based strategies guided by research. So let me frame the challenge. As you know, as you're aware, we've made tremendous advances in our knowledge about what causes youth problems and how to prevent those problems and to promote positive youth development. This increase in our knowledge has led to the syntheses of the research from the development of the original blueprints list to a report from the national academies that Bob Listenby described this morning. And those syntheses of research have also led to the development of different online registries with the goal of making it easier for policymakers and practitioners to find out what works. And as the number of people here at this conference demonstrates, a legitimate movement has emerged in support of evidence-based strategies on both ethical and fiscal grounds. Have you gotten your I Love EBP t-shirts yet? I'm sure there's a booth out in the lobby that's selling these. So that's the good news. But the adoption and implementation of evidence-based programs is still disappointingly limited. Equally disappointing is the fact that programs and strategies that have clearly been shown to be ineffective or even harmful are still supported and in widespread use. So this really frames the dilemma in the work that I do and should inform the dilemma in the work that all of you do. As with any breakthrough innovation, and in this case I'm referring to the development of the Blueprints Initiative, the challenge is how do we get our knowledge about what works to change the field so significantly that effective strategies become the norm rather than the exception. The pictures here are a good reminder of how difficult it can be and how long it can take to introduce a new technology. And when we think about the evolution of computers and wireless communication technology, we're also reminded that it's just that, a continuous evolution, with cycles of research and development leading to better and more usable and effective technologies. Like the evolution of cell phones, our current portfolio of blueprint programs face the challenges of convenience and usability. And whether we're researchers or program developers, policymakers and funders, or practitioners implementing blueprint programs, we need to recognize the practical challenges of adopting and effectively implementing these programs, regardless of their strength of evidence. I think the recent changes to the Blueprints project and the Blueprints website really acknowledge this evolution in our thinking. In particular, I'm really happy at the change in title from the Blueprints for Violence Prevention to the Blueprints for Positive Youth Development. I think that really signifies a continuing evolution in our thinking about these interventions. Policymakers and practitioners in particular should see themselves not simply as recipients of the knowledge about what works, but part of the research and development team that provides input to researchers and program developers. So if you're currently implementing one of the blueprint programs, I ask, are you simply getting training and going off to do your work? Or are you continuing to maintain a relationship with a program developer or trainer as part of a feedback loop? I think this is something that we could really improve on. This applies to policymakers and funders as well. I think there's a model that's prevalent across the country in how we are making use of evidence-based programs and strategies that is sort of unidirectional. Policymakers and practitioners receive information about which programs are effective, they get trained, and they go on their way. And that really doesn't help to inform this idea of continuous quality improvement and moving the blueprint programs and evidence-based programs in general to something that looks more like that iPhone that I showed you. So the challenge then is getting beyond these lists to really moving the needle on key indicators of public health and public safety. And that's a distinctly different endeavor than simply telling people what works. And this conference already feels like a watershed to me. In conversations that I've had in the hall with people this morning, in listening to the comments from Bob Listenby, and in the first session that I went to this morning, it really feels like we're reaching a next level in the sophistication of our thinking about blueprint programs and what it takes for them to really make a difference. So let me tell you briefly about Pennsylvania's 20-year adventure, and it has been an adventure, in attempting to take this innovation, the blueprints, and apply it at a scale that could impact outcomes at the whole community or state level. And again, that's really what we're trying to be about. Pennsylvania's funding for the development of the original list 20 years ago, as Bob Listenby mentioned this morning, created a unique sense of commitment and investment in Pennsylvania. So Pennsylvania has Pennsylvania feels that it was there in the beginning of the development of the original blueprints list. And so it's continued to be committed to understanding what it takes to have the development of that list, that originally started with reviewing over 500 programs and identifying the small number of programs with really strong evidence of effectiveness in rigorous, well-designed trials. What does it take to have that make a difference in population-level outcomes? We've been quite successful in increasing the adoption of many different blueprint programs in Pennsylvania over the last 20 years. As you heard, nearly 300 replications of blueprint programs throughout Pennsylvania. And this map that you see only represents the blueprint programs that were funded through this initiative that I'm describing, funded by the Pennsylvania Commission on Crime and Delinquency. So we have been quite successful in this goal of dissemination. And we've seen some positive outcomes from this. We did a 5-year longitudinal study in Pennsylvania where we looked at over 400 classrooms or age grade cohorts of kids from different communities in Pennsylvania. And we compared kids from communities where they were implementing blueprint programs in a specific way that I'll describe in a minute. And we compared them to other communities, other kids in Pennsylvania where these programs weren't being implemented. And what we found was pretty impressive. Nearly 11% lower rates of delinquency, nearly 11% lower rates of self-reported negative peer influence, 16% better self-reported school engagement, and somewhat surprisingly, 33% better academic achievement comparatively. But again, I think the diversity of these outcomes speaks to one of the fundamental underlying tenets with these evidence-based programs, and that is that they utilize a public health framework of acknowledging the underlying risk and protective factors that predispose kids to a wide variety of different poor outcomes. So by not narrowly focusing on a specific outcome that's narrowly defined, like bullying or truancy or school dropout or violence or school violence, but instead focusing on this collection of underlying risk and protective factors, we get the collective impact of affecting many different outcomes. So this initiative that I'm describing in Pennsylvania was rolled out by the State Crime Commission primarily to address delinquency and youth violence. And it had an impact on those. But because we were addressing the underlying risk factors, we also saw outcomes in other areas as well. And that has implications for return on investment as well. If you're getting impacts on multiple outcomes, that changes the whole equation of cost-benefit. And we've also seen the impact of blueprint programs on systems utilization, such as the placement of juvenile offenders, in which counties using the blueprint programs showed a decrease in the use of confinement compared to counties that had not yet adopted any of the evidence-based intervention programs like MST or FFT. And last year, Pennsylvania joined the growing list of states that are actually closing youth correctional facilities. Can I get a round of applause for that? This represents some important practical challenges. Again, Bob Listenby this morning talked about what a political challenge it is to close an existing operating correctional facility that is staffed, and often staffed with, union employees who are part of a strong union that can push back against closing that facility and losing those jobs. Especially when these correctional facilities, as they often are in Pennsylvania, are in rural areas and become important sources of employment. They become some of the biggest employers in some of these rural areas. But in Pennsylvania, the governor carefully and thoughtfully addressed those issues and provided resources to the community where they were closing this youth correctional facility. One of the most important, I think, and impressive aspects of the closing of this facility in Pennsylvania, though, was the fact that in the press release where the governor announced the closing of this 100-bed youth correctional facility, he specifically said that he was going to take $10 million that was to be saved from closing that youth correctional facility and reinvest it back into evidence-based programs and strategies. Now, I have to say, in the spirit of transparency, that about half of that $10 million disappeared in the ensuing budget negotiations. But again, that reflects the practical realities of tight budgets. But it doesn't change the fact that the governor made the commitment and recognized the connection between evidence-based prevention and intervention strategies and reducing rates of delinquency and ultimately closing this youth correctional facility. So what have we learned over this 20-year adventure that I could share with you? And I'm not up here to insinuate that that Pennsylvania has solved all of its problems. You've probably already heard some disappointing news about different things going on in Pennsylvania. We still have what I think is an unacceptable rate of youth incarceration, although we're making significant progress in that area. But we have been on this adventure for 20 years, specifically trying to scale up these evidence-based blueprint programs, and so we've learned some lessons that I think are worth sharing. First, dissemination of evidence-based programs, dissemination of the blueprint programs is not the goal. And this is a mistake. This is a mistake that I think we made in Pennsylvania, and I think is still being made in a lot of places at the state level and at the federal level. We have confused means and ends. We have gotten so excited about the fact that there are some things that we know work that we sometimes want to push those evidence-based programs, those blueprint programs, out into communities without doing the necessary problem identification and diagnosis and data-driven decision-making to know that that particular program makes sense in that particular community to meet a specific identified need. So think about if you went to the pharmacy, or think about a context where the medical profession was simply trying to get you to take as many drugs as possible because they've all been FDA approved, right? All the drugs in a pharmacy have been empirically validated, right? They're all evidence-based. But we don't just try to get you to take every drug possible just because they've all been proven effective. We need to, you need to go to the doctor first and find out what are your underlying symptoms and issues, and then make an educated, informed decision about which of these evidence-based strategies is going to be most effective. Another lesson we've learned is that a tool is only as good as its application. So like many of you, I would guess, I often spend my Saturday mornings in the local home improvement store. That's my addiction, and I admit it. Recently, at the local home improvement store, I was there on a Saturday, and they were having one of their little Saturday free workshops, and they were explaining the wet saw. This is what you see in the picture here. This is called a wet saw. And this 99 out of 100 general contractors will tell you this is the tool to use if you're trying to cut ceramic tile. I didn't know this. I know this now. So I was enthralled. They were doing demonstrations, and I got to actually cut some ceramic tile. It was all very exciting. And I came home several hours later, as sometimes happens, from the home improvement store, and I walked into the house, and I was very excited, and I wanted to tell my wife all about the wet saw. The wet saw. I told her all about it. And she was in the kitchen when I walked in and shared all this great news with her. And she was making Jello. Well, she had made Jello the night before and put it in the refrigerator. I don't know. I also, in addition to not knowing anything about wet saws, I don't know anything about making Jello. But she had made the Jello, and she had put it in the refrigerator the night before. And she had gotten it back out, and she was in the process of trying to cut it. And I don't know if you know, but apparently it's really challenging to cut Jello. It's very difficult. You have to get it at just the right consistency to be able to cut it so it doesn't crumble. And she said, well, I don't need a wet saw. Can a wet saw cut Jello? So, a tool is only as good as its application. So again, think about our example of the pharmacy full of evidence-based medicines. We not only need to know which of those medicines is right for our specific symptoms, but we need to know how to effectively administer that medicine for it to really be an effective tool. And that's difficult. That's challenging. Another lesson that we've learned is about the limits of technology without capacity. Sometimes I think about this because I've worked in my professional career. I worked before what I think about as the Age of Enlightenment, and I've worked after the Age of Enlightenment. And it really does. It helps me to think about it that way because there was a whole period of my career where my job was actually to go around and tell people what they should be doing, what programs and strategies, specifically in juvenile justice, they should be focusing on. And a lot of it was based on, anecdotal information and best practices. And in fact, some of my frustration in the early part of my career was that I was working in policy, I was doing policy work, and I was one of the only people of my professional career, my professional peers who was trying to occasionally read academic journals. And when I would occasionally read academic journals, I would be constantly reminded that the very things that I was promoting in policy flew squarely in the face of what researchers were finding worked and didn't work. So it's important to consider that there have been decades of work in the areas that we're all working in trying to address youth problems and trying to promote positive youth development and build stronger families and stronger communities. There have been decades and decades of work that took place before any of this evidence that existed, right? So it's important to recognize that because now that the light has come on, now that we are enlightened, it's going to take some time to retool the entire systems that were built around an absence of evidence. So this is an important point. I think there's a myth that is quite common in this area, and that is the myth of the empty vessel. Now that we know some things that work, It's not like there's an empty vessel out there in communities just waiting for that knowledge and we can drop this new information into that empty vessel. We're having to displace things to make room for these evidence-based programs, these blueprint programs. We have to displace programs sometimes. We have to displace ideas, for sure. And it requires a whole technology of building capacity to utilize this new technology. And we really, I think we haven't yet dedicated enough attention and resources to giving our cows opposable thumbs. Now, in Pennsylvania, this issue of that I mentioned earlier of using good diagnosis to inform our decisions about how to most effectively use the blueprint programs is accomplished primarily through the communities that care model. And I know that many of you are familiar with communities that care. I know there's already been mention of it, I think in the morning plenary and certainly in the morning session that I attended. But just quickly, communities that care is a data-driven strategic planning model that helps communities do this kind of diagnosis that I talked about. Figuring out, based on good local data on risk and protective factors, what are the most prevalent problems in their community, but more importantly, at a universal community level, what are the most prevalent developmental pathways and combinations or constellations of risk and protective factors that are leading to those specific problems. That's really important. It's one thing to know how many 8th graders reported smoking marijuana in the past 30 days. That's important to know. It's more important and more helpful to know what are the specific constellation of underlying risk factors in your community that are most likely driving that marijuana use, because it could be very different from one community to the next. And knowing that difference might inform whether you choose a prevention program that's focused on changing peer norms, or you focus on an evidence-based program that's about changing the availability, or you focus on a program that's about strengthening parent connections and the messages that parents give to their children about the consequences of youth drug use, or what the family values are. So Pennsylvania installed this communities that care model as a foundation before attempting to roll out and scale up the blueprint programs in Pennsylvania as a way to, like I said, create fertile ground to really prepare communities. And over the past 20 years, we've implemented this communities that care planning model in about 120 communities, and some of those didn't last. As with anything, if it's funded on soft grant money and times get tight, sometimes these initiatives, they just don't survive. And sustainability is an issue and a challenge in everything that we're talking about. Currently, we have about 65 functioning coalitions in Pennsylvania that are doing this work. And like anything, scale creates challenges. Going to scale creates specific challenges like maintaining good fidelity to the process and keeping these community coalitions trained and on task in the face of member turnover. But this scale has also offered us the opportunity to do things like develop mentor coalitions for other coalitions and develop learning communities. So communities are working with each other to learn together as a collaborative, to form regional coalitions of coalitions, and to establish in-state training and technical assistance capacity. One of the critically important issues in scaling up blueprint programs and using the communities that care infrastructure in Pennsylvania has been to the development and implementation of the Pennsylvania Youth Survey, or PAYS. So this is a statewide survey that collects this data that I described on the underlying risk and protective factors, community by community, and gives communities the kind of locally specific profile that they can use to make decisions about resource allocation and to prioritize strategies. Importantly, through a recent collaboration across state agencies in Pennsylvania, the Pennsylvania Youth Survey is now available at no cost to any school district or community in Pennsylvania. As a result, last year we had about 3/4 of Pennsylvania's 500 public school districts participating in this biannual survey. This will also aid, in addition to local decision making, having this number of school districts, 3/4 of the school districts across the state participating in this kind of risk-focused profile identification. This will aid in doing data-driven strategic planning at the state level as well. And states should mirror this data-driven strategic planning process. So a key lesson in making good use of the Blueprint programs is really about data-driven decision-making and strategic planning using community monitoring systems like Pennsylvania's Pennsylvania Youth Survey, or PAYS. And if that's not in place, and you're making decisions about the adoption of programs and strategies, Blueprint or otherwise, I question what is guiding your decisions other than the fact that these programs are on a list, which is important but not sufficient. Another important capacity I think we need to strengthen in the field is practitioners and policymakers' understanding of what evidence really means, that term evidence, and why it's important. Because that has a big impact on how they interpret the value of the Blueprints programs and the value of the Blueprints initiative as a whole. And it also helps them to understand the many different registries and directories of evidence-based programs that are available and out there. We've gone from not enough information to an embarrassing abundance of resources that are sometimes creating more confusion for communities and policymakers. So, in summary, to improve outcomes, we need to bridge the gap between science and practice. Pennsylvania is really focused on bridging the gap between science and practice through this clearly articulated logic model. The policy agenda of promoting the greater use of evidence-based programs is quite common now, as you saw by the T-shirts, as is the focus on fidelity and sustainability as challenges regarding evidence-based programs and Blueprint programs. What I think is still missing from the conversation, though, is the foundation and infrastructure that will help this evidence-based agenda achieve its promise. We need to also be careful that we're supporting not only specific evidence-based programs, but also building the capacity of providers and communities to do good prevention and intervention work generally. This is the interactive systems framework for dissemination and implementation that we use as a sort of a logic model to guide the work that we do in supporting the Blueprint programs in Pennsylvania. And I wanted to share this, specifically the piece where it talks about general capacity building in addition to innovation-specific capacity building. I think that we're putting a lot of attention and focus and resources on, for instance, training and helping a provider agency to be really good at delivering MST, right? Because MST is a Blueprint program, and we know that it takes intentional focus to make sure that it's delivered with high quality and fidelity and that it's sustained over time. But in 20 years of doing this work, I literally have never, ever encountered a provider agency that is only delivering evidence-based programs or only delivering one program. And that means that we've focused a lot of attention in this provider organization on how much attention and focus they need to place on being a good provider of MST, and we've unintentionally created this dichotomy against all of the other programs and services that they deliver. And if we're not building their capacity generally as a provider organization, we may actually unintentionally be creating a situation where we've made it more challenging and less attractive to do the very things that are likely to be most effective. So we need to think about not only building capacity in provider organizations to do a blueprint program well, but to do everything they do well. And that's a point that I think we really need to shift our focus a little bit if we're going to move this whole agenda forward and not continue to have the kind of pushback that we've seen historically by some groups against this idea of a specific menu of packaged interventions. Another issue, both at the community level and at the state level, is the need for backbone organizations that are vital to creating the kind of collective impact rather than disparate and competing efforts that diffuse impact. So we're recognizing that there are many initiatives and many programs and strategies going on in any community, and there needs to be some sort of supportive backbone infrastructure to connect and organize all of those efforts. Communities That Care is a good backbone infrastructure at the community level, and I think the epicenter that I direct in Pennsylvania is a good example of that kind of backbone organization at the state level, working across multiple initiatives. And above all, even the best programs can't always overcome systems barriers. We've really seen this, for example, with the struggle to utilize behavioral health managed care funds to support programs like MST, FFT, and treatment foster care in Pennsylvania. We moved in that direction pretty early on in the dissemination of the blueprint programs because we saw MA funding as a good potential sustainable, stable source of funding to support these programs. But the MA system existed long before there was this evidence base, and it was not set up and structured with the idea of supporting programs that require a specific type of fidelity to implementation. And so sometimes the trade-off of the financial support of MA funding is that we have to bend on things that are important in relation to implementing MST or FFT or treatment foster care with fidelity. And so it's really important, if we're thinking about really getting to scale with any of these programs, we really need to work closely with policymakers to address these system issues and barriers and challenges. All of these recommendations are really about changing the environment, the systems context, and really increasing the capacity of providers in particular to do their work in the most effective way possible. And that will require us to shift the focus of what we've been promoting, shift the focus of the way we've been promoting and using blueprint programs. In particular, as I mentioned, greater focus on capacity building at scale. This, I think, is the next frontier for the blueprints. Less what and more how. We've really focused over the last decade in trying to identify what works. Now we need to really focus on how do we make that work in natural non-research conditions at a scale that's really going to move the needle on important public health outcomes. And including a shift away from a culture of compliance to a culture of excellence. And finally, as my mentor, my idol, Bill Nye, the science guy, says, it's not magic, it's science. And science is hard and sometimes slower than we'd like. But in the end, it's science that creates the changes that feel like miracles. Thank you. I was going to say something about this, but I don't want to spoil it for anybody who DVR'd it because they weren't home on Sunday. Now, do we have time for questions? Okay. Time for about 2 questions if there's somebody that has a burning issue. Yes. Wait, they're bringing a microphone so everyone can hear you.
Hi, Karen Blasey from the National Implementation Research Network. Fantastic talk, such important messages for us, as always, also hugely entertaining. So I'm very interested in the degree to which EPIC and your work are beginning to think about and with other states. So Pennsylvania is a great exemplar in many ways, still lots of issues to deal with, of course. But what are the, thinking up a level to what are the core features of the work that's gone on in Pennsylvania and your way of sort of constructing those, many of which you've talked about. Are there any state-to-state partnerships emerging where people are saying, oh, we'd like to be the next Pennsylvania-type initiative, and what do you think it would take to get there?
Well, there are a couple things that have been going on. Over the past, maybe 4 to 6 months, I've participated in about at least 5 different big collective multi-agency meetings at the federal level between different federal agencies where they're focusing on these issues of getting to scale and at the same time maintaining quality and fidelity, making sure that the use of evidence-based strategies is not dogmatic but practical and working towards some goal. So there's a lot of, I think there's a growing aggregate interest across multiple federal agencies, and I'm really excited that they're working together in putting together these different forums, including one that David Hawkins recently led by the Institute of Medicine and National Academy of Sciences. So there's conversation at the federal level, which is good, and that's necessary. A practical step that just began relatively recently, the Annie E. Casey Foundation has put together a learning community of what they call centers of excellence for the promotion of evidence-based programs and practices. And that group just recently had a first meeting. I know that a handful of folks here in this room participated in that meeting. Unfortunately, I was out of the country and couldn't attend, but Stephanie Bradley, who is the managing director of the Epicenter, represented us, and I hear it was a really incredible first conversation. So hopefully that will take things forward. One more quick question.
Over
yes.
here. Hi, I'm from New York City, and I just want to say thank you for making it safe to spread the spotlight on looking at unintended consequences. I was in a workshop earlier this morning, and I asked the question, it's really great that we've got this full continuum of EBM models in a system and that there's been an increase in the number of models in a system. But what are some of the unintended consequences that results for providers, for communities, and for families? There are some families that do not fit the criteria, and so other providers in the system now must absorb the overflow of those families. And so there are many other unintended consequences, but thank you for making it safe to ask the question about what are we doing to help systems respond to the unintended consequences. Thank you.
Sure, and I think in the macro sense, it goes back to what Bob Lisenby talked about this morning. That in the end, this has to be about the kids and families. It has to be about improving outcomes for kids and families. And we absolutely can't set up a system or a context where they're worse off for having been through our programs or services or systems. I think an important part of that, though, is this issue that I mentioned about not having our whole agenda about moving out evidence-based programs be dogmatic. It has to be practical and practically applied in a way that's really focused on improving outcomes. And part of improving outcomes is not unintentionally setting up a context where we put providers under, where we've screwed the screws down so tightly to try to drive forward this evidence-based agenda without understanding the local context, that that we are putting good providers out of business, in forcing them to sort of dismantle things that they've been doing without knowing. I mean, believe me, I'm all about, I hope it was clear, I'm all about stopping things that we know don't work. And certainly stopping things that are still in widespread use, that are iatrogenic, that are harmful for kids. And there's a lot of low-hanging fruit in this country that we could make progress on in that area. But there's a whole other, there's a lot of other things that providers are doing that may or may not work. We just don't know. And I think it has to be an intelligent, informed decision about whether or not it's a good thing to stop doing something just to make a room in the vessel to implement an EBP. Okay. Well, thank you very much. Thanks for your attention.
Okay, so I hope that we're all agreed we're off to a good start on this day. And now we'll start the workshops for the afternoon. There are 2 separate sessions, so you have until 1:30, about 10 minutes before we start those workshops for the first session.